So I somehow have to cover all of lymphoma in 20 minutes, so here we go. These are my disclosures, but really what I want to do with this talk is kind of catch everybody up to speed with how rapidly some of the standards of care are changing, and many of these are standards of care that were present for 20, 25 years, and for years and years that needle never moved, and now they're starting to move, and they're starting to move very quickly. So a really excellent example of this is Hodgkin's lymphoma. Uh-oh. Okay, there we go. All right, I'll slow down because I'm getting click happy. Okay, so this is a curve from Echelon 1. So this was the randomized trial of brentuximab AVD versus ABVD that originally was read out several years ago at ASH, and a lot of people were sort of waiting for this overall survival data to show up, right? Because there was a progression-free survival advantage, but the brentuximab vedotin was much more toxic, it's more expensive, and so people are saying, hey, look, unless I really see an overall survival benefit in this disease where people typically do well, it's gonna be really hard for me to wanna adopt this therapy. So now about a year and a half ago, we got 6 years of follow-up on Echelon 1, and you can see here that the PFS benefit remains with A plus AVD or brentuximab AVD maintaining its PFS benefit over standard ABVD. And we did get a suggestion of this overall survival benefit. Now, obviously, this was a secondary endpoint, but it is statistically significant. And finally, people said, okay, so this is what I was waiting for. Maybe now I'm going to start using brentuximab AVD or A plus AVD as my standard of care for stage 3 and stage 4 Hodgkin lymphoma. Almost immediately after that data was presented, this overall survival benefit, we got SWOG 1826. And this was presented initially about a year ago at ASCO. And this was a randomized phase 3 study of nivo AVD versus brentuximab AVD in stage 3 and stage 4 Hodgkin lymphoma. Study design was relatively straightforward here, and the idea here is to maybe get away from the brentuximab. Now, clearly, based on Echelon 1, the brentuximab works really well, but it absolutely causes more neutropenia than standard ABVD. You have to use growth factor, and it definitely causes more peripheral neuropathy than standard ABVD. So there's the potential here to improve toxicity as well as improve outcomes. So this study actually got presented early. The SWOG DSMB actually suggested we present this data relatively early in terms of toxicity. Indeed, the nivo, so one thing to know about this is in the nivo AVD arm, the growth factor was not mandated. It was kind of at investigator discretion versus the brentuximab AVD where it was mandated. And you can see for the most part that worked out with 98% of people in the BV arm getting it and about 54% of people in the nivo AVD arm getting it. But we can see here is that there's definitely more neutropenia after the nivo AVD arm, but this hasn't really translated into more, say, febrile neutropenia, and you are using less growth factor by using the nivolumab instead of the BV. Peripheral neuropathy, as you can imagine, if you take out the brentuximab, the peripheral neuropathy goes down significantly. And of course, we're using a PD-1 inhibitor, so we do have to think about the autoimmune toxicities, but really they weren't all that prominent. Perhaps it's because we're only giving 6 cycles or 12 doses here, but you can see here the amount of grade 3, increase in transaminases, hyperthyroid, those sorts of things were relatively low. And here's the primary endpoint. This is the 1-year PFS. So this is early. This data was read out quite early, so we don't know exactly what's going to happen with longer-term follow-up, but certainly at the 1-year mark, the PFS favors the nivo AVD arm. In terms of looking at specific subgroups, was there any particular subgroup that tended to benefit from the nivolumab? The short answer is no. And if you want to dive into some of this a little bit deeper, at ASH this year, there were presentations both on the AYA population as well as the population specifically over 60, breaking down the outcomes in those arms. And spoiler alert, they both favor the nivo AVD arm. So overall survival, it's way too early to see a change. Maybe there's a little bit of a suggestion, but it's just a bit too soon. This is, again, only 1 year of follow-up at this point. And so these were the conclusions that were presented as part of the initial abstract presentation. So you can see here that the nivo AVD improves PFS. It's extremely well tolerated. There was this whole thing about consolidative RT. One thing about the study that was actually really interesting, it's one of the first times the adult and the pediatric groups have worked together. COG was actually a huge part of this, very important in its design. So this is actually a huge step forward, not only towards advancing the stage of the care of Hodgkin lymphoma, but actually harmonizing the way both the pediatricians and the adults treat Hodgkin lymphoma. So this is not FDA approved. There's some logistics about how to go to the FDA with this because of how early it is and how the data was collected. I highly suspect in the next year or two that ultimately Nivo AVD is going to be the thing that's going to be our standard of care in stage 3 and stage 4 Hodgkin's, which is to some degree a little bit crazy to think about after ABVD being the standard of care for so long. In about 5 or 6 years, we've actually bumped 2 more standards of care. So I do think that this is going to be the future. Obviously, we do need longer term follow-up, but I think there's been enough experience, not only from the Hodgkin's literature, but from other diseases of PD-1 or PD-L1 inhibitors plus chemotherapy and those regimens maintaining their benefit. The rest of the world's a different story, and I think using these more expensive drugs is going to be an issue. But in the US, I think this is where we're going. And now let's move to something a bit more common, which is diffuse large B-cell lymphoma. But again, kind of a similar story where R-CHOP has been the standard of care, aside from us having some occasional arguments about when to use dose-adjusted EPOCH. But for the most part, R-CHOP has been king for over 20 years, and it's been hard to move that needle. So let's talk for a few minutes about Polarix. So this was a randomized phase 3 study of our polatuzumab, which is a conjugated CD79A, plus CHP. There's too much neuropathy when you use both the vincristine and the polatuzumab. So it's the R-Pola CHP versus standard R-CHOP. And you can see here that this is for IPI, this was 2 and above. Otherwise, basically took all comers with diffuse large B-cell lymphoma. And so what was kind of interesting is when this was originally presented at ASH a couple of years ago, and then there was a paper in the New England Journal, we had a lot of debates about whether or not this would become standard of care, and then about a year later it got FDA approved, so we started having those debates again. But in terms of overall response rates, CR rate, PFS, all of these things slightly favored the Pola RCHP arm. Is there any particular subgroup that tended to benefit from the R-Pola CHP? One thing that has kind of stood out is actually the cell of origin. This unfortunately didn't project super great here, but the ABC subtype, I forgot what assay they used here, if it was nanostring or not, but the ABC subtype did tend to do better than the germinal center subtype here. And at first, some of us thought maybe this was kind of like a mathematical curiosity, but it turns out if you go look at some other studies involving polatuzumab, that same trend was seen towards the non-GC or the ABC subtypes benefiting more, and there actually might be some biology behind it. The subtype might be more dependent on signaling through CD79, and so perhaps it's not just mathematics or some biological rationale as well. So many of us have moved towards using this, perhaps in our patients with high IPI or non-germinal center subtype. Some people have moved towards saying, look, the study was done in patients with an IPI of 2 or greater, regardless of their cell of origin, so I'm just going to give this to everybody with an IPI of 2 or greater, and you can absolutely make that argument, and that is how some people and some practices have moved. So this becomes a really interesting question. You know, you have to decide for yourself how you want to manage the DLBCL patient who's in front of you. But this also becomes a really interesting question as we're designing clinical trials going forward, because so many studies for years have been R-CHOP plus X versus R-CHOP, right? And so if you are today designing an upfront DLBCL study, you have to decide what's going to be your standard of care arm. Is it still going to be R-CHOP? Is it going to be R-CHOP or Pola CHP? And you let the clinician decide. Is it going to be our Pola CHP? So this is going to make comparing clinical trials a bit more complicated going forward, because some people are picking investigator's choice, some people are sticking with R-CHOP, and some people are using the R-Pola CHP as their standard of care arm. So over the next couple of years, as we get studies that are like R-CHOP plus a bispecific or R-CHOP plus whatever, we kind of have to decide if we think that was an appropriate comparator arm, and then we have to sort of decide how to look at all of these other regimens. So it's getting a lot more complicated to find your space and design your upfront DLBCL study because of this kind of variability in how people are looking at this data. We have no idea how using the Pola upfront is going to affect relapse. If you're somebody who always uses Pola BR when they relapse, you may have to rethink about that now if you're going to start using the polatuzumab upfront. I have a whole talk in and of itself on CNS prophylaxis, so I won't spend too much time here, but this is just to say that this is already a controversial topic. And then if you start using a different backbone, if you start using R-Pola CHP, you have even less data on what you should do with CNS prophylaxis. So we have the standard of care is shifting and things are getting more complicated, and we have a lot of question still to answer, but at the same time, we are taking big steps forward and getting more people cured upfront with DLBCL. So then the other kind of ongoing question we're grappling with now is bispecifics. This is not unique to lymphoma. We're dealing with this in multiple myeloma as well. Which one should I use? When should I use it? And which patient should I use it? So I don't have answers to all of these questions, but I can tell you a little bit about what's available. So in diffuse large B-cell lymphoma, we have 2 CD3, CD20 bispecifics that are FDA approved. One of them is glofitamab, and you can see here the rates of CRS. Most of this is grade 1 or grade 2, very rarely is it grade 3 or grade 4, but it's not 0. And you can see some of the other toxicities is here. In general, with all of the things we're not supposed to do with cross-trial comparisons, if you look at the response rates to these bispecific antibodies in relapse refractory DLBCL, it ends up being about 50%. So glofitamab, this is the toxicity profile. This one is given IV. This one has actually the potential, though, for a limited number of cycles, depending if patients have a PR or a CR. There is an indication that after a certain number of cycles, you can stop this therapy. That's in contrast with epcoritamab. Again, it's also a CD20, CD3. This is their data. This is their kind of response rates and their CRS profile. This one tends to have a little bit less CRS, and when it has CRS, there's a little bit more grade 1 than grade 2, but again, it's kind of this was kind of a mixed bag, this particular study. This kind of lumped together a bunch of lymphoma subtypes. This one is subcutaneous, which some patients really, really like. But at this moment, this one is approved as an indefinite therapy. And I find for some patients that's really appealing. And for some patients, that's a bit of a barrier to wanting to go on it. So again, we're not supposed to do cross-trial comparisons, and in both are good drugs and probably have similar outcomes. So I think a lot of it becomes about the logistics, deciding between which one you're going to use for each individual patient. So they differ in terms of their route of administration, IV versus subcutaneous. They differ in terms of the duration of therapy. There's the ability to stop the glofitamab eventually versus for now, the epcoritamab is approved as an indefinite therapy. And when you admit the patient potentially for their CRS monitoring is slightly different between the two. Both of them do have an admission, though, for CRS monitoring at this point in time. That may change. The epcoritamab is going to do a study looking at only outpatient administration. I think they added another step-up dose to mitigate some of the CRS. But that may change over time. But for now, no matter which one you pick, the patient is likely going into the hospital for about 24 hours for monitoring. And I have found that I often will present both, or I'll just sometimes I just have a gut feeling, and I have patients on both, and I've used it on a case-by-case basis. So just a sample of diffuse large B-cell lymphoma clinical trials, just so you can get a sense of what some of the questions are that are being asked right now. So I do have 2 upfront studies. One is an S1918, which is our mini-CHOP with or without oral azacitidine, and that's for patients age 75 and older who have generally been very understudied in diffuse large B-cell lymphoma. We're doing our best to change that with this study. We will have an R-CHOP plus a bispecific. Lots of companies are rolling those out right now. We do have a number of cell therapy studies, including allogeneic cell therapy studies. People are asking the question CAR T versus bispecific, and then the wild card that will eventually enter the race will be these allogeneic cell therapy products, as well as dual targeted CAR T products looking at more than one antigen. We're also trying to optimize the standard of care CAR Ts that currently exist. We know that not everyone is going to be cured with their CAR, and we know that the patients who achieve a CR to their CAR are going to do better than those achieve a PR or stable disease, and can we make that better? And we even have some stuff targeting EBV lymphomas, a study called NAVAL-1, and if you have any questions about any of these, feel free to reach out to me. But this is kind of in addition to trying to figure out when to use therapies, then the question is, how do we optimize what we have? And so this is kind of a cool study, because what we're trying to do is say, look, we know that CAR T can be potentially curative for some patients, but how can we move the needle and make it curative for even more patients? So this is a study where patients are getting randomized actually based on their day 30 PET. For the patients who are already in CR, fabulous, they are likely to do well, and they just sort of stay on observation. For the ones who are PR PR or standard disease, the standard right now would be to just sort of watch them and cross your fingers and just sort of be thinking about what you're going to give next once you get a hint of relapse. But in this study, the patients are getting randomized to either mosunetuzumab, polatuzumab, or the combination of mosun pola. Mosun is another CD3, CD20 bispecific that at this moment is only approved for follicular lymphoma, but that may change over time. And then just to kind of throw the wrinkle in this is how are things going to change? The study was kind of opened before our Pola CHP officially got its FDA approval. So now we're going to have to kind of grapple with if some of these patients have received polatuzumab up front, how we're going to handle this. So in terms of, again, sort of paradigms changing, right? So one thing that I sort of see happening in the field of follicular lymphoma is potentially getting rid of chemotherapy, which still has a role and I still use it, but it could be that that's eventually going to go away, kind of the way it did in CLL. So right now we have a study looking at standard of care versus one of the CD20, CD3 bispecifics actually for first-line therapy of follicular lymphoma. There's a few other studies like that as well. And there's a SWOG study that I don't think officially has a number yet, but it's actually going to be looking at mosunetuzumab, that specific bispecific, versus rituximab, actually for low tumor burden FL, to kind of go back to that age-old question, right? We still tell patients we're not going to cure their follicular lymphoma, but a lot of those early studies were done in times when the therapy was either not effective or not toxic. So if we go back to some of those questions that we haven't looked at in a while, if the drugs are more tolerable or more effective, if we actually did treat someone with something incredibly tolerable, very easy, is there the potential to cure at least some subset of follicular lymphoma? And obviously this is a hypothesis, I don't know, but that was actually the rationale behind this study of the mosun versus rituximab. I want to talk for a second about mantle cell lymphoma, because this is another one where the standard of care is changing really, really rapidly. I actually had a patient come see me before I put this talk together, after I put this talk together, and the space has gotten so confusing that I was the third of 4 different lymphoma experts in the region he sought out to talk about the data to try to figure out what in the world he should do in his individual case. And so one of the things we've kind of had to come up over the last couple of years is the addition of BTK inhibitors to standard chemotherapy. We had the SHINE study for people with the bendamustine rituximab backbone, and then there was what's called the triangle study, kind of looking at a more intensive induction regimen and the role of the addition of ibrutinib. But this could be another disease where, at least for some patients, maybe we get rid of chemotherapy. And so this was a study of ibrutinib plus venetoclax versus ibrutinib plus placebo, and this happened to be a relapse refractory population. Primary endpoint was PFS. And you can see here that the combination of the 2 oral targeted therapies was better than using just the ibrutinib alone. Overall survival was trending towards the combination, but again, secondary endpoint, not that much, not a very extremely long follow-up and all the caveats there, but a trend towards perhaps improved overall survival. And in terms of toxicity, it was really exactly what you would expect. It was basically the toxicities of the 2 therapies that you know about kind of slammed on top of each other. There was a lead-in of the ibrutinib, so it decreased the risk of the TLS with the venetoclax. But you can imagine when the venetoclax and the ibrutinib was on board, there was a little bit more leukopenia and things like that. But overall, it ended up being a relatively well-tolerated combination, similar to what we've seen in similar combinations in CLL. So I have a lot of questions about the role of BTK inhibitors in mantle cell lymphoma, and so this study begs the question, if there's anybody you're considering giving a BTK inhibitor to, should you just add the ven at this point? And maybe, I think one of the subgroups I struggle with, and I was speaking to somebody about this earlier, is I'm feeling like lately I have a bunch of people who have TP53 mutations in mantle cell. And so obviously I'm not going to give those people chemotherapy, but should I give them this combination? Should I hold a bullet or hold the therapy knowing that they're only going to get so much mileage out of the first one because of the TP53 mutation, and save the ven for when I need it, in a year and a half or so when they come out of remission? Is the benefit of the same if I use a different BTK inhibitor? I think overall we've sort of moved away from ibrutinib in most settings because the other drugs look similarly effective, if not better, with a nicer toxicity profile. So if I was going to use Acala or Xanu, is that going to be the same benefit using the combination? And are more people going to get BTK inhibitors up front? Like I mentioned, there's data on ibrutinib plus BR. There's data on ibrutinib plus these intensive inductions, kind of that we've often given to our younger patients with mantle cell lymphoma. And if more people are going to give ibrutinib up front or get a BTK inhibitor up front with chemo, then what do I do at relapse? And there's even more questions, and for the sake of time, I won't go there, about the role of transplant, and we're trying to figure that out. And we actually might be moving away from autologous transplant as the default for everyone with mantle cell, with at least for the younger patients with mantle cell lymphoma. Okay, so that was way too much in 15 or 20 minutes, and I'm going to stop now so you guys can ask questions.